When I woke up that day, then it was, unfortunately not what we had hoped for, but the cancer was gone, and that's ultimately all that mattered.
Hi, this is Patrick.
And this is Laura.
And you're listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. National leaders in cancer. I definitely think a lot about what people go through when they get treatment for cancer, but I don't think about infertility issues that can happen afterwards. And this episode was so eye-opening to me.
Mindy had an incredible story, finding out that she had cervical cancer at 28. I'm sure that was very scary for her. But then on top of that, her and her husband are trying to get pregnant and start a family.
And I think you're going to hear another perfect example of how much the physicians at Siteman care about their patients. I think you're going to learn a lot about infertility in general and about how you can help someone that might be going through it.
Today we're joined by Mindy, who is a cervical cancer survivor.
That's correct.
And we're also joined by Washington University physicians, Dr. Lindsay Kuroki and Dr. Kenan Omurtag. Thank you guys for being here today.
A pleasure.
So nice to be here.
Can you tell us what each of you do with Washington University and Siteman?
Yeah, I'm a G1 oncologist and an associate professor in the Department of Obstetrics and Gynecology.
And I'm the chief of the Division of Reproductive Endocrinology and Infertility and one of the fertility physicians at the clinic.
And one of the reasons that you're here, Kenan, is because, Mindy, with your story of getting cervical cancer, you were 28 years old. That had a major domino effect on your ability to have children after being treated. So we should probably start from the beginning with you, when you were diagnosed, how you were diagnosed, and then what the treatment was.
So I went for just my regular GYN appointment 1 year, and I had been having a little bit of increased discharge. I mentioned that. She said, I'll check everything out. Some women just have that. So she did my exam, said everything looked fine, went on with life.
Yeah, no red flags there, right?
Right, yeah. Year later, go back again for my next appointment, and I'm still having the same symptoms, and mention it once again. And I actually saw a different provider this time. And they were like, we'll check it out, do your pap, everything like that. And that's when she did my exam. She found a spot on my cervix. She's like, has anybody ever mentioned this before? And I was like, nope, not that I know of.
And actually, Mindy, wasn't your pap test normal?
Yes, my pap that day was normal, the day that they found the spot. Yep.
So she found it by doing the physical exam?
Yeah.
And you said it was a different physician that time. Was that just by chance, or did you go, man, I'm having the same problem. Can I see somebody different?
Well, yeah, I actually both.
Okay.
I chose to see somebody different, but I just, going in with no complications or whatever, you kind of just see whoever is available at the time. But yeah, I chose to not see that one again.
And Mindy, was the pap, did you have a pap the year before?
I want to say she did one just because I had mentioned something, but I know that none of my paps that I've ever had been abnormal. I'd never had an abnormal one, even that day that they found it, which was crazy to me. But once again, that's way over my head.
Well, yeah, because you think that the reason you're going to get a pap smear is to find things.
Right, exactly.
Yeah. Exactly. So that would make sense that you'd be startled that there wasn't anything on the pap results. Right.
So found it that day. From there, they scheduled me to get a colposcopy in the office, just take a biopsy. That was within, a few weeks of finding it. And then from there, I got a phone call while I was at work, actually, telling me the results from that. And that it was actually the adenocarcinoma, and that she was sending a referral in for me to come up to the GYN oncologist in St. Louis. And then it was just a whirlwind from there.
I feel like I just need to pause, because what you just said, and when I was, reviewing your case, it's quite powerful that your OBGYN provider saw a lesion and that pap test was normal. Mm-hmm. And there's been a lot of talk, I guess, in the medical community of, do patients really need an exam if they aren't quite due for a pap test or a cervical cancer screen? And this is just like a perfect example of someone found this pre-cancer. And the specific type of pre-cancer that you mentioned, it's the adenocarcinoma in situ. It is HPV related. And it oftentimes is detected on cervical cancer screening. So this was, I mean, kudos to your referring provider to do the right thing, see the lesion, biopsy it, and then follow up on the test results.
Right.
Yeah.
And can I piggyback off of what you just said? Because I'm 47 years old. Every year I was going in to get a physical exam and a pap smear from my gynecologist. Something changed in the last 5-6 years, is that correct, about how often you're going to get an actual pap smear when you go to get the physical exam?
Yeah, our guidelines are generally set by the American Cancer Society and the U.S. Preventative Services Task Force, and there has been some discrepancy and controversy in terms of the starting age, but also depending on what screening test people are using. Generally, if a negative HPV test and a normal cell test or cytology, people don't need to get rescreened until 5 years later. So when Dr. Omurtag asked about, like, Mindy, did you get that pap test the first time? If it was normal, honestly, there was really not an indication to redo a screening test.
That's what I know. They weren't going to do it that next time that I came, and they actually found the spot. I know that I wasn't due for one. I remember her saying that. She's like, I'm going to go ahead and do one since we found something today.
Oh my gosh.
Yeah.
That's crazy.
But also,
which either way, it was still negative. So.
Yeah.
right, but you're supposed to be going and getting a yearly exam as a woman, a physical exam from your gynecologist every year, correct?
Yeah.
Well, one thing I wanted to kind of walk back a little bit for the listeners is to talk about, people sometimes talk about, I went to the doctor and got a pap, and sometimes that's conflated with an actual pelvic exam. Mm-hmm. A pap smear is a specific type of screening for cervical cancer. And I think most people that are listening might know that, but some may not. But oftentimes patients will conflate those terms. So I went in to get a pap when I actually just went to get a pelvic exam, and I didn't actually get a pap smear. So that's something that we educate patients about. Not every pelvic exam comes with a pap smear. Every pap smear requires a pelvic exam, though.
Gotcha.
I did not realize that either until I kind of went through all this. I was like, well, I don't know. They did an exam. I just assumed that they're, doing a pap. But
So are we still calling it pap smear, or has it changed? Because I've heard it different now from younger people I know that call it something different.
So I'm going to go to Dr. Kuroki on that.
So actually, we used to technically call it a pap smear because what we would do is collect the cells and smear it on a slide. But now, because of how advanced we've become in terms of our screening technologies, we don't technically smear anything anymore. And so we truly call it a pap test.
So enough people finally went, ew. To where you guys went, fine, we'll call it a test.
And I also think this is just a good illustration of where language evolves with time, and language actually matters when we're having these conversations with
100%.
patients.
So I'll ask the question just because I think most people do. When they told you that you had cervical cancer, did you know what your cervix did?
Essentially, yes. I am a nurse, so I knew a little bit, but I don't know all the details. But yeah, I mean, I know what it does.
Lindsay, what does our cervix do?
Well, in and of itself, it does relate to holding the pregnancy in the sense that if the cervix dilates, it sets people up for preterm delivery, preterm labor. But in and of itself, the cervix doesn't have an actual vital function. But in order for a pregnancy to develop to full term, you do need what we actually term like a competent cervix, meaning it has to be able to dilate when it's supposed to dilate and to really kind of keep its length in order to allow that baby to develop over 9 months.
Gotcha. And it's the canal to the outside world when the baby comes out. That's why they always say you're 1 centimeter, you're 4 centimeters dilated.
That's the cervix.
Okay.
Mm-hmm.
Yeah, and from a fertility standpoint, while when you deposit sperm into the vagina, that sperm then travels up through the cervix, and then that sperm attains necessary functions as it transits through the cervix and the uterus, and then gets into the tube, so that it can then fertilize the egg.
Gotcha. You guys are all probably too young to know this reference, but our audio engineer will know. The John Travolta movie where
Yes.
the baby was talking. What's that movie?
Look who's talking.
Look Who's Talking.
Who's Talking. I
And
know
the
that
sperms were making their way.
Yeah.
And
The
they were
Beach Boys
The
song.
Beach Boys. That's the cervix.
Yes.
Love it.
Yeah, so for anybody that doesn't understand what the cervix is, just go watch Look Who's Talking. It's all right there.
Yeah. Okay. Mindy, let's get back to you, shall we? You were called during work to be told that it was cancer. Do you remember anything about that?
Yeah, I remember standing in the bathroom. I went to the bathroom because I knew it was the doctor. I don't know. It was kind of just like a overwhelming feeling. It was just shocking, honestly.
You were 28.
Yeah. It was the very beginning of December. I think
Yeah.
the first time I saw Dr. Kuroki.
What year?
Your
2021.
biopsy was on November 9th, 2021. And then that biopsy showed those precancer cells, the adenocarcinoma in situ. And then
December 20th maybe was.
December
That's when we
20th,
first-
2021 is when we did your conization.
Yeah.
Her what?
And that the conization, which is a larger excision, and that is what confirmed your cancer.
So that was a cervical procedure to get a bigger sample to see what exactly you were dealing with.
Yeah, this has really raised a lot of attention in the world of OBGYN because the type of precancer cells that you have, the adenocarcinoma in situ, it is classically known for having skip lesions.
Skip lesions?
Skip lesions, meaning that abnormal cell might just have a cluster, and then behind that it might be normal, and then another cluster. Whereas a lot of other precancers, you think it's just a continuum. And so the really critical thing here was to take a larger excision, but to also consider the margins. And margins are of that piece of tissue that you take out. Is that cut end that still is in the patient, is that portion of that tissue have cancer cells, precancer cells, or is it completely normal? And the false sense of security with Mindy's case is that adenocarcinoma in situ has skip lesions. So the margins are so critical, but it doesn't provide that guaranteed, true negative margin.
So what did that, once you were able to, confirm this is what it was, what was the treatment plan?
Well, so we did get clear margins. So that was like promising. But as she explained, with the skip lesions, you can never be too safe. I think that's what I'm trying to say. So I went for a PET scan. I think that was the next step, which had to wait a little bit because I think the scar tissue can show up on the PET scan.
From that big biopsy.
From the PET scan did show, I think, an area in my cervix still. So then ultimately we decided to do, we for sure knew we wanted to do lymph node biopsies. So that was going to be another procedure. And then we had talked about doing the tricholectomy, which is removing my whole cervix. And then the ultimate goal, obviously, was to preserve my fertility. Haven't had kids yet. So I should have just been an easy patient and said, just take it all out and be done with it, but would have loved to carry my own kids. So, we kind of went the harder route and decided to do the tricholectomy. So got, then worked up for that. And that was the ultimate plan going in. But it, as we know now, it's not, unfortunately, how we woke up. So
these decisions of what best treatment options to offer when our patients desire future fertility, these are some of the hardest decisions that we have to really think through. And so I actually presented Mindy's story at our multidisciplinary tumor board to not just, provide her what I thought was my best opinion, but to really get the collective consensus opinion from my group at Siteman. And so we reviewed not only her PET scan, the MRI, we reviewed her pathology. The pathologist reviewed with us both the conization as well as, the details of all the planning, including REI, the reproductive endocrine infertility folks. And part of the surgical counseling for anyone, it's always what the recommended treatment was, which is actually the radical tricholectomy. It just means removing the portion of the cervix that we think has the cancer, but then actually preserving her fertility, reconnecting the uterus to the vagina. So you basically reconstruct the ability to carry a pregnancy in the future.
You kind of reroute the cervical tunnel for the baby to exit.
Exactly. And then in doing so, we actually intentionally place a cerclage. And a cerclage basically cinches that new cervix, essentially, that we create so that it can hold the pregnancy. And then we keep the tubes and we keep the ovaries. And then we sample the lymph nodes, as we should for anyone that has a diagnosis of cancer.
So I don't think I shared this with you when we spoke on the phone the other day, Mindy, but my lung cancer was an adenocarcinoma, and we caught it early stage. So similarly, they were just like, surgery right now,
Right.
just get it out. And I had clean margins, but they did find it in 2 of my 9 lymph nodes, which meant chemotherapy.
Right.
So then I found myself having similar consults with doctors because my wife and I wanted to have kids.
Right.
So chemotherapy, you can't be getting pregnant when you're on chemo. And then I did 2 years of a clinical trial, which is something else we always talk about on here because clinical trials are incredible. And I know you didn't have to go through a clinical trial, fortunately, but it's a pretty nice lifeline, like to pair with, chemo or surgery. But that was another 2 years for me where we couldn't be getting pregnant because of the drugs that I was on. So I froze sperm and met with, doctors and talked. I had the same conversations that I would imagine you and your husband had.
Right.
So
it's a lot all at one time.
Yeah.
Because you don't know what's going to happen.
Right.
So you have to have those conversations, and it's kind of a rushed process because you don't know if you're going to have to start the chemo and radiation and go from there.
There's like a sense of urgency too.
Yes.
Which can kind of like cloud your.
Yeah.
It just makes the decision tougher.
It's
for
just
sure.
a whirlwind, honestly.
Yeah. Yeah.
When you went in for the surgery, you were intending to do that reconstructed cervix, but when you got in there, is that why you said then you had other plans because you realized you needed to take her whole cervix in surgery?
Yeah. So we had up front talked about that possibility of, it's always, there's so much trust that we ask of our patients as surgeons. The worst case scenario is to have someone wake up and just not know why we did a certain part of the surgery. And so we had discussed that possibility. The intention was always to preserve her fertility. That was the priority. But we also did talk about that possibility of during the surgery, we send the tissue to the pathologist, and they are looking under the microscope and looking at the margin that we provide. And
just real-time results.
Real-time,
informing the
exactly.
surgery.
Yeah.
That's incredible.
It adds time under anesthesia.
Yeah.
But it's very much worth that time, especially when fertility is on the line. So what we did is we were able to remove that portion of the cervix, and we sent it to the pathologist. And the pathologist said that margin was positive for cancer. So no harm, no foul. We took another small portion of the cervix, shortened it a little bit more, sent that to the pathologist, waited another 30, 40 minutes. And the phone call back was that it was positive for cancer. So I took an additional slice, and at that point, I called in Dr. Powell, who actually saw Mindy in consultation before surgery. He had participated all along in the tumor board discussions, and together we decided that would be the last possible shaved margin that we could offer. So with that, I, along with the specimen, went down to pathology. I was just waiting and waiting.
Stakes are high.
Yeah, I wanted to look at the tissue myself, and they said there was still cancer on the last biopsy. So I just remember this phone call to your husband. He was in the waiting area, and I was in the pathology suite. And I just expressed my My apologies. That was I never had to do that before.
I said I wasn't going to cry.
I know, me neither.
Well, it wasn't your fault. You did everything you possibly could do and more. So I don't want you to ever think that it was your fault or that you didn't do everything you could, because you did. So
and we knew what the right thing to do was.
Right.
That was the best piece of this, is that we knew exactly what we needed to do. There was no doubt that we were going to go back in and give you a cure of cervical cancer. But at the same time, our hearts were broken. You know?
Yeah.
I mean, put yourself, for the listener, just put yourself in a moment. I mean, to summarize where we've gotten, we're going into this major procedure with an opportunity to potentially cure this cancer while preserving fertility, with the caveat that, hey, there's a chance that we might have to remove the uterus and the tubes entirely. And, we see this all the time when we're doing these consults for fertility preservation, because we're having the conversation in proximity to all these decisions. And it is very true. Patients like Mindy, in those moments, you're given a diagnosis of cancer. You're then expressing a desire to preserve fertility. You're then meeting with us, and we're talking about all the things that we can offer and the whirlwind that comes with that, physically, mentally, and oftentimes financially. Right. So it's just all this all at once, and it is a very combustible, emotional, physical, and financial explosion. Right. And you are in the middle of it with your partner and with your support group, and then with us. So you can appreciate how emotional we as the providers are just as much. But the amazing thing, I think, is that we have been here before with people.
Right.
And this is not our first rodeo. And we can look people in the eye and we can be like, I know where you're at. We will get you there. And right. I think that's where, we went.
Yeah. Yeah. I mean, it was literally I absolutely love roller coasters, but this was the worst roller coaster I've ever been on in my life.
Would not ride again.
At the same time, it has been the best roller coaster. So then when I woke up that day, then it was, unfortunately not what we had hoped for, but the cancer was gone, and that's ultimately all that mattered.
And Dr. Omurtag, I would imagine, I'm sure you see that all the time. How do you help them?
Well, I think you first acknowledge the circumstance, and empathy is kind of the calling card of what we do. And increasingly, it's becoming more and more focused part of what we have to do. So normalizing, reminding people that you are not alone, as cliche as it sounds, it's actually true, because we see all these patients. We see patients just like Mindy. We see patients who are walking in the door in this crisis, and we're there to reassure them that there are actually a lot of ways to build a family. And there are a lot of people out here building families in a lot of different ways that maybe you read about or see about, but are actually very accessible to everybody.
Right.
Yeah.
And then we just basically, I tell people all the time, look up the word assuage in the dictionary, assuage, ASSUAGE. Look it up. If you're listening to this right now, just Google it. Look at the dictionary.com definition, and it means to make a bad situation less bad. And that is exactly, they should just put a picture of a reproductive endocrinologist in the dictionary, because that's literally all we do is assuage, because constantly we are bombarded with people in crisis.
So when you're waking up and you find out that this procedure had to turn into a total hysterectomy, what happens from there?
So then the next question was if I was going to have chemo or radiation. So that, went back to be discussed and everything. So in the meantime, if you're going to have chemo or radiation, you have to have, I'm going to have my eggs retrieved before that. So that's when everything kind of got very rushed.
This would all be happening post-op, though, right?
Yes. I mean, yeah. And it was like post-op. Then it was, we've got to retrieve your eggs if you're going to have chemo.
How did you retrieve her eggs if she had a hold? Okay, because I'm Dr. Omurtag. I'm like, I really want to ask this question.
Right, because
in
now
my mind,
I'm like, but you had a hysterectomy.
Where are the eggs? Were they like out somewhere? Were they on it? Where were they?
Well, there's a couple.
Just hanging out.
Were they like in a freezer somewhere? Where were the eggs?
There's two things let me say first. One, when someone has a hysterectomy, that's just a reference to the uterus being removed. A lot of times, just going back to language, sometimes we conflate oh, I had a total hysterectomy. Are my ovaries still there? Those removing the ovaries, removing the tubes are actually separate procedures. A hysterectomy is just removal of the uterus. So at this point,
I never knew that. When I heard total hysterectomy, I was like, okay, they removed fallopian tubes, ovaries, uterus, cervix, the whole shebang.
Dr. Kuroki?
What we removed was the cervix, which is where the cancer was, and the uterus. The tubes we removed as well, and then we removed the lymph nodes just to make sure that it had not spread.
But the ovaries are what hold the eggs.
Yeah. So we cut the ovaries. Yes.
Which is
all
really
together now.
Which we can work with.
Yes.
So that's so the first thing. I just wanted to make that point about
that was a
language.
Crucial point.
I think that's important. Second thing is there's a lot of conversation about grief. GYN oncologist, reproductive endocrinologist. I'd like to think what we do on the fertility side, we are constantly dealing with grief cycles. You're pregnant, you're not pregnant, it worked, it didn't work, you miscarried later, you didn't get pregnant. Like we're constantly dealing with grief. And we're constantly confronted with how our patients handle grief because they're constantly in crisis. Many of them are angry. Many of them are in denial. Many of them bargain. Many of them accept. Mm-hmm. And I think Mindy's experience highlights how resilient patients are, but also how demanding it is of the providers and the team to be able to juggle all the different reactions that come in the grieving process and to still keep the focus, to have the emotional intelligence to keep the focus on the patient and not about how you're reacting to their grief.
Yeah, it's a lot of assuaging.
It's a lot of assuaging. Thank you, Patrick.
I think about that. I think about that every time I go to see my oncologist. The mental gymnastics that these people have to do when they walk out of one room and go, whew, okay. And then they turn to go, all right, Mr. Phillips, how are we doing today? I mean, it's each room, these people are in completely different places.
Yes.
And you guys are expected to just be on it all the time.
You're constantly, in one room, you're having a conversation with Mindy and her husband. You go to the next room and you're telling someone, after 3 years of IVF, you finally got pregnant and the pregnancy failed. In the next room, you're telling all within the span of 45 minutes.
Right.
Okay, so then you guys chose to go ahead with harvesting the eggs. Is that correct?
That's correct.
And did you have to do that a couple times, or I don't know how that works?
No, it worked on our first round. Dr. Omurtag can explain how we got to that point a lot better than I can. I just know there was lots of needles involved.
Yeah, so here we go. Let's dive right in. So it's springtime. You're getting into this surgery. We don't know what's happening. Now we know. We learned that you don't need any additional treatment. That's awesome. We have a conversation kind of basically saying this is how the process works. Let us know when you're ready. You come find us 3 to 4 months later. It's now fall of 22, and you're like, now we're ready. Perfect. Do you have periods? Of course not. You don't have a uterus, okay? Do you have a sperm source? Yes. We can work with that. Is that sperm source normal? Yes. So we want to do an assessment. We want to make sure the sperm's okay. It is. So now we're going into a situation where we're going to create tissue. So then the next question is the sperm source a reliable one? Do you want to create embryos? Or is this, a committed relationship? Is this a boyfriend? So these are the important questions. Obviously, I know the answer already, but these are the kind of questions we're trafficking in, okay, when we're having these conversations with patients in Mindy's situation. So married, trying to get pregnant, wants to have a child, we're creating embryos. So then we lay out a roadmap for how we do that. And that roadmap takes about 2 weeks. But before we lay out those 2 weeks, you have to medically clear, you have to financially clear, and then we just got to schedule you. We obviously also know that these tissues have to go somewhere else. They have to go into a gestational carrier, aka a surrogate. We use the term gestational carrier because that literally just applies to someone who is providing a uterus. A surrogate has an older connotation that means someone who might provide the egg and or the uterus. But the gestational carrier terminology just applies to someone who's carrying. So Mindy already knew that she was going to be using a carrier.
Was it someone that you knew, or was it through a
agency
kind of thing?
No, it's actually one of my best friends. Shout out to her. She's amazing for doing this for us. But yeah,
That's beautiful.
And there's a process. So Mindy says, this is who I want to be my carrier. And then we're like, okay, well, tell us a little bit about her. We want to make sure usually these people are under the age of 45, ideally under the age of 38. They've had at least one live birth before, so that they kind of know what the expectation is after delivery, so it's not so foreign when they're now giving the baby to somebody else after going through that physical process. So that's important. And then, making sure we understand what their medical history is, what their prior obstetric history is. Did they have preterm delivery? Did they not? And, this was kind of a slam dunk situation. We created the embryos first, and then we put one into the carrier later.
But there's like a process they have to go through to make it to the embryo stage.
Gotcha.
And then, so 6 of ours made it to where then we have 6 embryos that were available to transfer into a surrogate.
Yeah, so there's a couple things here.
Carrier, I'm sorry. Transfer into a carrier.
Gestational carrier.
Gestational carrier.
Gestational carrier.
You can only fertilize mature eggs. Not all mature eggs will fertilize. 50 to 70% is the expected fertilization rate in assisted reproductive technologies. She gets 14 embryos. These are pre-embryos. And then they grow in the lab for 5 days. And on the 5th and 6th day, she has 5 to 6 embryos available. They're then frozen. So she has 5 to 6 embryos. Now, not all embryos result in live births.
Right.
So there's probably a 50% chance of each of those embryos resulting in a live birth. So her and Steven probably have enough embryos to build their family, assuming they want 2 to 3 kids.
So we ended up transferring in June 22nd of this year.
And what was the result of that transfer?
Well, we are currently going to be 22 weeks pregnant on Saturday.
Yeah.
Wow.
Yeah.
That's incredible. Congratulations.
That's
Thank you.
amazing.
Thank you.
First try.
First try.
Wow.
Still can't believe it, but it worked.
That's so great.
Yeah.
So, where were you? Where was your headspace at in your journey in August when we were talking about doing embryo transfer? And then where was it at the time of the transfer? Because the transfer itself is a culmination of a lot.
Yeah. Honestly, my head was everywhere. Over here, you're so excited. You're finally moving towards your ultimate end goal, of having a child. And then over here, I'm a nervous wreck, because it might not work. We're putting forth the effort, the money, my friends' time too. I didn't want it to be for nothing, So I'm just everywhere. But the day of the transfer, honestly, we were so excited. Once we finally got to the point where we knew who our carrier was going to be, she was excited about it. She's like a pro. This is her 6th kid. So I was like, she can do this, she can do it. And we just, trying to keep positive thoughts only. And I just had this good gut feeling, honestly, about it. We went up to the clinic that day for her transfer, and, we were just both excited. And I was like, I just have good vibes today. This is going to work. It's going to happen. And that's how it's been ever since, honestly. So,
and that's a comment that whenever we do these consults on patients who are in the middle of this diagnosis of whether it's cervical cancer or whatever cancer it is, one of the first things we tell them is, we'll ask them what is your understanding of why you're here? And usually it's well, I want to preserve my fertility, ... And then usually our response is, you're here because you're going to beat this.
Right.
And you're here because your team believes it's important to address your life after cancer, because you will have a life after cancer, and reproduction is a big part of that. So we kind of put that out there so people kind of are emboldened to get that, because in this moment of crisis, we're trying to build you up.
Well, and that's honestly, I would have never thought about that as quickly as we did if they wouldn't have, pushed us to go talk to them and get that ball rolling, because at that moment, all you can think of is the big C word, you don't think about the next year or two, what you're going to want your life to be like, so thank you to them for pushing us to do that, as overwhelming as it is, it's, it's the best thing that we could have done at that time, because now we have that to think about rather than the negative parts of that time. You know what I mean?
Dr. Kuroki, that must make you feel so happy because you were so tearful earlier talking about having to tell her and just to be able to hear her talk about a baby coming that has to give you some I don't know, just some
where
peace.
are you mentally? Yeah.
Some peace.
I was a sloppy mess. No, I'm just kidding. It was just, we see each other every 3 months for the first 2 years out.
For follow-up, right?
For follow-up, just to make sure she's recovered well, that she has a reassuring exam. This is just to make sure that cancer has not come back. But we were also having these side conversations about the reality of financial, issues of how to coordinate care, timing. I remember you were moving at the time and
there was a lot.
There was a lot going on.
Yeah.
There was a lot going on. And at that time, it was, I'm sure you remember, I actually was pregnant with my own daughter, which made it even more heartfelt at this time because, as you mentioned, when you're trying to share your personal life and I'm trying to help support you and be sensitive to everything you're going through, those conversations, I also was coming in very nervous into,
She was trying to hide her belly, and I was like, get over here and let me see your belly.
Yeah.
The two of us together, we were like two peas in a pod. And I'm so grateful that you were allowing me to be part of that journey with you, not just compartmentalize the cancer. It is you. Everything, meeting your mom and surgery and meeting your husband and being part of this story with you. I was celebrating big wins over in my office when I heard about the transfer and the success. And we're so excited to meet this little baby.
Do you guys know what you're having?
We're having a boy.
Oh, awesome. Congratulations.
Thank you.
Nice.
This is not simple stuff here. It's miracle level stuff to make this happen.
Right.
And not all journeys are the same.
Right.
Yeah.
Not all journeys are the
Some
same.
are short, some are long.
Yeah.
You just need to make sure, and that's the nice thing. And I think that's the thing we're trying to highlight here is that you've got, a GYN oncologist who's on that journey with you, and you've got your reproductive endocrinologist on that journey with you.
But I think it's worth noting two things, though, when you have a cancer diagnosis on top of infertility, and then after you beat that or while you're trying to beat it, you're now talking about infertility. It is something that I think most people don't think about when it comes to cancer is that massive side effect of infertility or what the treatment could do to your fertility or could do to your future of fertility. And we're not talking, you don't meet fertility patients just who had gynecologic cancers. You also have breast cancer patients or prostate patients.
Leukemia,
leukemia,
lymphoma, brain, all of it. We see it all.
And that's just from all these different types of cancers. And I don't think you hear a lot of people talk much about infertility in relation to cancer. You must have a large population of your patients that you have to worry about their infertility when you're treating them.
Yeah, I think it's a forced question. It's not even on people's radar or even something that they would have even thought about having that conversation. But because of their cancer diagnosis, it's immediately brought in equally just to address as important as what are the next steps for the cancer management? What are the next steps about your fertility? And unfortunately, when a lot of these cancers we're asked about the surgery, a surgical intervention that could possibly be tailored to their fertility options, it really is, it's a hard situation to be in because only a select few are we able to offer a surgical fertility sparing surgery. Otherwise, they are more or less referred to Dr. Omurtag's practice knowing that they're going to need treatments that are going to diminish their ability to either carry or have a pregnancy.
Dr. Omurtag and Dr. Kuroki, what would you say are the things you're most excited about when it comes to treatment and fertility in general?
I think probably where the field is moving is in more personalized medicine. Immunotherapy is really exciting. We're starting to build clinical trials. I think we're learning to be smarter about surgeries, actually. In the last 5 years, there's a big initiative to look at surgical outcomes and how they impact survival. And so actually the way that I performed Mindy's surgery through although albeit an open incision, we know that those outcomes extrapolated from radical hysterectomies are better than doing it minimally invasive. That's like something new, and we're continuing to build the information we know. It is a truly an exciting time in cervical cancer. I think the opportunities to personalize medicine through looking at the genetics of the cancer are just opening up a lot of treatment options for our patients.
Yeah, that's very promising for sure. I had no idea that a minimally invasive surgery for hysterectomy maybe it didn't have as good of an outcome.
Yeah.
Crazy. Dr. Omurtag, what about you?
I think the two things. One, I kind of mentioned previously, which is this rising opportunity for philanthropic monies in this new age donor class that I think is going to be available to help support people on these fertility preservation journeys where there are gaps in coverage. And then the second thing is ovarian tissue cryopreservation. Right now, it takes 2 weeks to harvest the eggs. And, in Mindy's case, we had that time. But in patients who might have leukemia, lymphoma, you don't have that much time. So having an opportunity to just do a simple minor procedure, laparoscopically remove some ovarian tissue and freeze it. We've been doing that for some time, but I think scaling it now is going to be happening over the next decade.
Mindy, what would you say to other women out there that are starting this journey, in the middle of the journey? What could you say to maybe help them so they could feel less alone?
Honestly, just that you're not alone. Honestly, one of the things that got me through this journey, like the infertility part of it, is a girl I work with actually had went through IVF too. And just talking to her step by step, literally, I can't even explain how much that did for me. Just truly knowing that you are not alone. And if I can do it, then anybody can do it. And also just, it's okay to not be okay at your own time. I know I'm not good at talking about my emotions. And like with grief, it's comes and goes at different times. And some days we're almost 2 years out. And, I'm like, we'll just have a day where I just want to sit at home and do nothing. And luckily I have a good support system. And one of my friends, she's always, takes up for me and is like, why is Mindy not coming out of her house? She's like, you know what? She just needs a day. And I'm like, why am I like this? We're pregnant, we're good, but it's just, it comes at different times. And it's just, I just try to tell myself that it is okay to not be okay when you need to, So,
That's great advice. Like Laura said, just thrilled to hear that you're cancer free and that's, hopefully just something in the rearview mirror and that you get to go forward and, keep building your family with your husband.
Yeah.
Mindy, I know you say you're not very good talking about your feelings, but you've done an amazing job today and you've been very open. So give yourself some credit on that. You are 100% a cancer survivor. Everything you had to do is 100 times more than I've ever had to do to have 2 children.
And what you shared today is going to help a lot of people.
Yes.
Anybody that listens to this
I hope so.
will get something out of this. So thanks again.
Validating. It's everything. So thank you for that. And thank you for both of you for saving her life and giving her a baby.
Thank you for me for that, because I would have never been able to get through even part of this without you guys. So thank you.
It's an honor to be on the journey with you.
Yeah, you were my favorite.
Oh, gosh, sometimes I wish we could just see in the booth and see all the love. Thank you, guys.
Thank you.
Thanks for listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis.
National leaders in cancer.
For more information on Siteman Cancer Center, go to siteman.wustl.edu and be sure to leave us a review and like and subscribe wherever you listen to podcasts.